Yeah, we are on live.
Yeah, I think Dr. Rakesh looks not there. So Rahul, please go ahead. Rahul, unmute.
Good evening, everybody. I am Dr. Rahul Agarwal. I am a physician in Medicover Hospitals, Madhapur, High-Tech City. And we all know that we are in the middle of a pandemic, the second wave, and anticipating the third one. And this second wave has been a little bit challenging in all of its glory. So we have been challenged with the type of treatment that we have to advocate in the early, middle, and late phase of the illness. And most challenging, as was discussed earlier, is the middle and the late phases when we are left with very little choices. Stem cell based therapy that we are going to discuss today, its applicability in the current scenario in COVID-19 patients, the real use of it and its promising future and career in the use of COVID-19, and our experiences till now so far is the current topic for today. I know it's a very difficult topic to be in 20 minutes to be discussed, and post that we will be having a lot of good sessions and extremely esteemed panelists that we have today with all of us. I would like Dr. Ganshyam, the speaker himself, to introduce few of them because he is better knowing most of the panelists than me. So over to Dr. Ganshyam.
Thank you, Rahul. I know it's a very interesting session for me personally because I am not an expert on stem cells. Neither have I used it ever in my life. But this is the first time that I was actually drawn into using stem cells, and I should thank Dr. Suresh Anne, who is here, because through his discussion in one of the WhatsApp groups, we thought of exploring this idea. So for the panel today, we have Dr. Suresh Anne from US, again, who is a professor in immunology. Dr. Sairam, who has done extensive work and is considered to be one of the experts in cell-based therapies. Mr. Nedun, again, one of the key members who has been involved in developing a protocol for us at Medicover Hospitals for what we, kind of made certain changes and use, the autologous bone marrow as one of the therapies. We will discuss that in detail. What I'm going to do is I'm going to just, make a very brief presentation. Again, as I said, I'm not an expert. It's been a very fantastic reading for me when I was trying to make this presentation. So we'll just go through briefly. Okay, let me.
By the time Ganshyam is able to come to us, I would like to introduce Ganshyam himself. He is a very dear friend of mine and has been into critical care for so many years. That is one of the names that we reckon with whenever there is a word critical care comes. So he has been the pioneer of doing a lot of innovative, and is not shied away by using things that has helped the patient to recover as soon as and as much as possible. That includes one of the earliest center to prone patient in ventilation, and to use tocilizumab when it was first in the market, also using other treatment options that were initially thought of whether or not it works or not, including now the stem cells. So over to you, Ganshyam.
Thank you, Rahul. So in the next 20-25 minutes or so, I'll just try to take you briefly through the role of stem cell therapy in COVID and share with you our own experience about the use of stem cell therapy in COVID-19. We are all aware of the pathophysiology of COVID-19 related pulmonary lung damage, as well as the cytokine storm, which is classically seen. We know that the pathogenesis evolves into 3 stages: the early viral replication phase, followed by the pulmonary phase where there is extensive lung damage, and the hyperinflammation phase, which has been classically defined as the cytokine storm, and which is considered to be the major cause of morbidity and mortality across a large number of patients who are suffered or suffering with severe COVID-19 disease. Now, if you look at the core aspects in the management of severe COVID-19 over the last 1.5 years, there have been multiple interventions that have been tried. But what one has realized over so many months of managing these patients is that the treatment per se evolves around 4 cornerstones or 4 pillars: the antivirals, which work in the initial stages of the disease. Immune modulation seems to be the key in improving outcomes of patients with severe COVID-19, of which steroids are the major players. Yes, there are a large number of other immunomodulators that have been utilized, but again, the kind of evidence that we have for steroids seems to be standing out. Anticoagulation, well, it's a different debate of whether you're going to use prophylactic versus therapeutic, but again, understanding the fact that severe COVID-19 is associated with significant thrombotic pathophysiology, anticoagulation is another very, very key aspect in the management. And lastly, we know that oxygen has been vital in whichever way it has been supported. But what we have all understood, and what the literature from different centers have reported, is despite having these core therapies for supporting severe COVID-19 patients, we still seem to have a very, very high mortality. And that is where we need to look at newer therapies beyond these 4 core pillars of the management of COVID-19. And that is where we started looking at the role of mesenchymal stem cells in the management of these patients. Just a brief, we all know that mesenchymal stem cells, or the multipotent stromal cells, can be harvested from different tissues, be it the bone marrow, be it the adipose tissue, be it the blood cells. What is interesting to us as an intensivist who is managing a sick COVID-19 patients, or the role of mesenchymal stem cells with respect to the management of a severe COVID-19 disease, seems to the fact that it has 2 key roles or 2 key areas. One is the effect that the mesenchymal stem cells has on the immune modulation. Again, this seems to be a multifaceted way it kind of modifies your immune response. It is by direct cell-to-cell interaction, plus the release of certain paracrine factors. The other key aspect is the release of growth factors. The other key factor is the release of growth factors, which seem to be playing a vital role in regenerating or repairing the damaged alveolar capillary interface, which is vital for the gas exchange. Apart from this, there is also some role that has been established through the release of microRNA particles, which can have some antiviral property. We also know that age seems to play a role, especially if you're using bone marrow as a source, because as you age, the number of stem cells decreases when you try to use bone marrow as the source of the mesenchymal cells. Now, I said, what is the rationale for the use of mesenchymal stem cells in COVID-19? There is one, safety has been very well established. Mesenchymal stem cells, or the stem cells, are not being used for the first time now. They have been used extensively over the many years for different indications, and their safety profile has been fairly well established. In COVID-19, the rationale is that when you give mesenchymal stem cells, there is something called a first pass mechanism, where the stem cells seem to lodge in the pulmonary vascular bed, which seems to be the key area for the immunopathogenesis in COVID-19. And these stem cells, once they get lodged into the pulmonary vascular bed, modify the immune response by interacting with the various cytokines, releasing chemokines, and both the innate as well as the adaptive immunity is modified, more towards a immunosuppressive state. Another key mechanism, as I've said, is the regenerative philosophy or the principles of stem cells, wherein they are involved in the release of various growth factors which help in the repair of the alveolo-capillary endothelial barrier mechanism. And as I said, yes, there is some amount of antimicrobial properties which have been established, but then again, there is something which has not been very well validated. Now, is there evidence? Well, there are lots and lots of phase 1 and phase 2, as well as preclinical animal data, which have been used not only in COVID-19 related ARDS, but other lung conditions where there were some benefits which have been established. Yes, we may not have very strong level 1A multicentric randomized control trials, but such a novel intervention may take time before we get very strong evidence in terms of numbers and outcomes. Now, this was a German study which was published recently, where they tried to compare mesenchymal stem cells versus the standard of care. Again, they chose the most severe subgroup of patients. All the patients were defined or which were involved in the therapy had a PF ratio of less than 100, who are considered to be severe, the most sickest as far as the respiratory failure is concerned. There were 5 patients in the mesenchymal stem cell group versus 18 patients in the standard of care. And if you look at the MSC group, 4 out of the 5 patients were on ECMO support, and in the standard of care group, 9 out of the 18 patients were on the ECMO support. The dose of the mesenchymal stem cell that they gave was about 1 million per kg over a 30-minute infusion period. 3 patients in the mesenchymal group got 2 doses, and 2 patients were given 3 doses. With respect to the baseline characteristics and the comorbidities, there was not much of difference between either of the groups. Similarly, when they looked at the various laboratory values, laboratory markers, or the inflammatory markers, again, there was not much of difference between both the group, except for the fact that the mesenchymal stem cell group had a higher temperature at enrollment. And if you look at the Murray lung score, which is an indirect evidence of the significance of lung involvement, the Murray score was significantly or more in the mesenchymal stem cell group, indicating that they were probably much more sicker. This was the results when they looked at the various parameters. This was at admission as compared to discharge. They found that the leukocytes and the neutrophils significantly decreased in the mesenchymal stem cell therapy group. The lymphocyte counts were significantly higher in the MSC group, suggesting a probable revival of the immune system. The CRP again was lower in the mesenchymal stem cell therapy group. The rest of the parameters like the ferritin, the IL-6, etc., there was not much of a difference. When they looked at the pulmonary mechanics or the respiratory parameters, they found that the PaO2 by FiO2 ratio or the oxygenation was again significantly better in the mesenchymal stem cell therapy group at discharge as compared to the standard of care or the control group. The other parameters did not vary much. What was also interesting to find was that the Murray score at admission, again, as I said, the Murray score defines the severity of lung injury, and the higher the Murray score, the higher the lung injury. The Murray score was significantly more in the mesenchymal stem cell therapy group at admission, and by discharge, they found that the Murray score had significantly reduced in the mesenchymal stem cell therapy group, again, probably hinting that the mesenchymal stem cells did help in a significant recovery of the lung function. With respect to the morbidity and mortality, the length of stay in the stem cell group was significantly larger, but that was expected as the majority of these patients were on ECMO, and the baseline severity was much higher. But you expect that a patient who's on ECMO is going to last longer. So probably that would be the reason why the length of stay was significantly higher. But what was interesting to find was the mortality. If you look at the mortality in the control group, again, in the standard of care group, it was 55.6% as compared to only 20% in the mesenchymal stem cell therapy. Well, I know that the numbers are not very, I mean, it was a very, very small trial, only 5 patients in the mesenchymal stem cell group as compared to about 18 patients in the control group. But what we need to identify, or what we need to understand, is that this trial involved the sickest of population. So probably hinting that such novel therapies should be reserved, or may be working well if you are looking at patients who are the most sickest. Now, apart from this, there are a large number of other trials which have looked at the role of stem cell therapy in COVID-19 treatment. As of now, close to 60 to 70 trials have already been going worldwide. Now, this is a small data where different sources of stem cell therapies have been tried, from the human umbilical cord, from the adipose tissue, from the bone marrow, etc., etc. And what has been consistently found across all the trials is that, one, it is fairly safe to use stem cells. Second, it seems that the stem cells seems to be well tolerated across all the group of patients. Well, there are hints that they are effective. Again, as I said, the numbers are not very great to demonstrate a significant outcome benefit, but they seem to be effective. Consistently, all the trials recorded a significant immunomodulatory effect by reduction in the inflammatory markers such as CRP, interleukin-6, TNF alpha, etc., etc. And all the trials hinted that stem cell therapy could be one potential alternate approach for managing sick COVID-19 patients. Again, if you look at the way stem cell therapies are evolving, this is not in COVID, but the number of trials has been consistently going up across the world. These are for the COVID patients. Again, there are multiple trials across the world which are currently involved in looking at the role of stem cells in the management of severe COVID-19 patients. And these are the numbers which indicate that different sources are being used to harvest the stem cells. Now, our own experience, where we have done autologous bone marrow stem cell therapy for severe COVID-19 patients, I should mention the name of Dr. Manjula Anugani, who was one of the key members behind the development of the protocol, along with Mr. Nedun, who is here with us as a panelist, who helped us devise this protocol, which could be easily applicable at the bedside. Dr. Vikas Reddy is an orthopedic surgeon who was one of the key guys in getting the bone marrow aspirate. So what we have done at our center was that we used what is called as autologous bone marrow stem cell therapy, where we tried to aspirate the bone marrow with a Jamshedi needle from the posterior iliac spine. In the initial couple of patients, we used the iliac crest, but we realized that the yield was not very effective. So we started taking the bone marrow from the posterior iliac spine. Initially, we thought that 10 ml per kg would be the ideal dose, but we realized that we were not able to get more than 50 ml, or we didn't go for beyond 50 ml because it was quite sometimes it was difficult to get more than 50 ml, because one interesting observation we found was that even the bone marrow aspirate was clotting, probably indicating the severity of thrombosis in COVID-19 patients. So once aspirated, we kind of transfused that into a collection bag which had the citric dextrose as an anticoagulant, and this was run through a blood transfusion set and would be given back to the patient as you would give any other blood products. Now, major concern that we had was whether this can cause fat embolism. We searched for literature. We couldn't find any evidence of fat embolism with autologous bone marrow therapy. At the same time, what we did was we pre-filter and post-filter. We did a microscopic examination to see if there are any clumps of fat globules which could potentially cause fat embolism. But again, we did not find any major clumps or large molecules which could be responsible for fat embolism. The use of this filter practically removes all the bone spicules, which could also be a potential, potentially involved when you're transferring the bone marrow aspirate, right? Again, I think again, I did this slide courtesy Dr. Manjula and Dr. Mr. Nedun, who is here. I think we realize that probably when you use autologous bone marrow, the cellular constituents are numerous. Apart from the hematopoietic stem cells, mesenchymal stem cells, there are a large number of other cellular components which are also key in not only causing the immunomodulation, but also influencing the phagocytosis and the other growth factors. The data so far at our center, well, this is just a preliminary data. The statistical analysis is still underway. We are going through all the respective parameters. Now, in all the patients, the standard of care included antivirals wherever it was indicated, steroids, methylprednisolone, the dose of 1 to 2 milligrams per kg body weight, and anticoagulation. This was the standard of care in all patients. In addition to the standard of care, in about 25 patients, we offered the autologous bone marrow stem cell therapy. And all these patients were severe COVID-19 because everybody was either on high flow nasal cannula, ventilator, or NIV. Only 2 or 3 patients were on 15 liters of oxygen. All patients were either on HFNC 60 liters, NIV full, and ventilator full support. So far, 20 patients have been discharged. There is 1 patient who is still on ECMO, day 25, and we lost 4 patients. Well, it looks very, very appealing, but I think there are still a large number of areas where we need to explore. I hope that we will get some answers today with the experience and the fantastic panel that we have. Probably we need to look at what should be the ideal timing for mesenchymal or the stem cell therapy in severe COVID-19 patients. Will it be just like any other therapy where early intervention would give best result? The dose has something which we still do not know. Even in our patients, we were not sure as to how many sessions we need to give. Some patients got 1 session, some patients got 2 sessions. So what would be the ideal dosing? How do we decide when to repeat the dose, or what should be the time frame? What happens to the stem cells? For how long do they remain viable into the system is something that, again, probably we need to have better answers. And what type of stem cells do we use? Do they matter? Where do we source the stem cells from, or which tissue? Again, does it make a difference if we use different stem cells for different patients, or we need to kind of have a protocol in that matter? Does preconditioning of the stem cells influence the kind of response we have? Patient selection, again, is going to be key. Are we going to offer this to mild, moderate, or the most severe of patients? What are the medical, legal, and ethical implications? Again, I would like the opinion of the esteemed panel. Cost would be, again, a major thing. One of the major reasons why we thought of autologous bone marrow stem cell therapy was that the mesenchymal stem cells, when we try to inquire or procure it from outside, it was pretty expensive, and obviously we need more data on this. But I think I thank all of you, and I hope that today's discussion is going to help us, get some answers to these questions, and maybe help a lot of people across the world in trying to develop their own protocols and help these COVID patients. Thank you so much.
Thank you so much, Ganshyam, for
Rahul, one more small thing. Dr. Kalyan is also here. Dr. Kalyan is infectious disease specialist and who also has been involved in treating patients with stem cells. Thank you, Dr. Kalyan. Despite your personal loss, you have taken time to be here with us. Thank you so much. Over to you, Rahul.
Thank you.
Good evening, Dr. Kalyan. I am Dr. Rahul Agarwal.
Good evening.
Dr. Ganshyam,
good evening.
That was
Actually, I am.
Sir. That was an excellent presentation, Dr. Ganshyam. New therapies, they have got their challenges, and understanding new therapies and applying them to practical knowledge is even more challenging. So as we have discussed, and there are so many unanswered questions of this potentially amazing therapy that we can now have with COVID-19. My first question to the panelists, it's an open question, is who is the ideal most candidate and what is the right timing for giving such a treatment? Dr. Suresh, if you could answer me.
Thank you very much, for an excellent overview of Dr. Ganshyam Garu. Now we had let me just briefly say a couple of things before we answer about that. Who is the ideal one? If I may ask Dr. Sairam to give briefly about how the stem cells actually working, and that's probably give some more information or insight in the whole treatment, why we are trying to adopt this in the patient that were really sick patients. So that's where we started with. So then I will probably give you a few of my experience, and then we can go in depth, into the questions. If I.
No, I think that yes, Dr. Suresh, that would be that would be really helpful if we can actually get some more insights from Dr. Sairam, who's been working with cell-based therapies for such a long time.
Thank you, Dr. Suresh. First of all, Dr. Ganshyam, fantastic presentation. I'm actually blown away. I'm also incredibly impressed with your results with the bone marrow stem cells. We use that a lot. I've done probably 400 cases with bone marrow stem cells, mostly in the musculoskeletal arena. Regarding the mechanism of action, as you mentioned in your talk, and Dr. Suresh always says, it's not the virus which is causing the problems, the cytokine storm, and that needs to be dealt with. So far, we don't have any medication, as you said, which helps with the cytokine storm and decreases the mortality. Even remdesivir, which is so widely used, WHO has, I think a few months ago, came out with a statement that it's not helpful. Coming to the mechanism of action, basically, the cytokine storm is from pro-inflammatory cytokines and the catabolic cytokines like IL-1A, B, 6 and 8, 12, tumor necrosis factor, etc. There are thousands of those, and we only know very few. What stem cells do is with exosome secretion and also modulating the macrophages and the dendritic cells, and also with their impact on the Treg cells and the Breg cells, altering the Th1 and Th2 ratios, M1 and M2 ratios. Bottom line is they secrete a lot of anti-inflammatory proteins and also anabolic proteins. And it takes care of that imbalance and alters the micro environment to a catabolic environment. So what it does is it takes care of all the lung damage. And also, more importantly, none of us are paying attention to it now, but it is an issue, is post-COVID syndrome or long haul syndrome. And it does do repair of the tissues and the organs which have been damaged. Some of the mechanisms you mentioned, but one of the most important mechanism is they actually jumpstart or stimulate the native stem cells which are in the tissues to get activated, and that's how the regeneration is happening. Contrary to the original thought process that stem cells home to the area of degeneration or inflammation, the homing does not happen. The injected stem cells differentiate into organ cells. That does not happen either. it's all through their paracrine activity. But end of the day, they're taking care of the cytokine storm and they're regenerating the tissues. There is no medicine or drug in medicine right now which does that. Secondly, there are 4 controlled trials. 3 of them are randomized control, 1 was non-randomized. And if you look at add the numbers, there are more than 100 patients in these trials. If you look at the data, what it shows is that it decreases the inflammatory markers. 2, positive CT scan changes are noticed in the treated patients. Recovery is faster, and there is a decrease in mortality. So we do have some clinical data. It's very preliminary, but a ton of animal data explaining the mechanism of action. In my mind, the fact that there are no complications reported, we analyzed about 200 studies where they gave parenteral stem cells for organ failure, different organs. And none of the studies showed any complications. Most of the studies showed organ regeneration. So it's a very safe therapy. It's effective. There's none like it right now. And my feeling is when it comes to the timing, the sooner you give, the better is the response. And I would like to commend all the doctors in India who are so proactive in exploring these options, because in US, it's actually, even though FDA gave us emergency use authorization, the doctors are not willing to use it because they're not familiar with it. And I would like to end it there.
Thank you, Dr. Sairam, for a brief and excellent view of the mechanism of action. And I just want to add a couple of things what Dr. Sairam said. We all know, I mean, I've been talking to many of you for the past year. It is not the virus. So virus comes and goes. It's like any other influenza virus. Even influenza, we see that ARDS in few patients and dying. I think who we are treating, especially the pulmonologists and intensivists, know that we see these patients, especially the coronavirus, respiratory viruses. There is mortality, but unfortunately, because of the widespread virus, this coronavirus SARS-CoV-2, the same 1%, 2% mortality is presenting into thousands and millions of deaths. So that's unfortunate. So that's why we're all aware of what's going on in this. It's probably, we need to look into more in depth of what exactly the mechanism is going on. As Dr. Sairam said, that it's an inflammatory reaction. We all know that this virus, body starts with defending any foreign antibody or foreign antigen. So here the virus comes in and start the inflammatory reaction, and many of that, the inflammation stops because their mechanism, whatever that defense mechanism, stops when the work is done. Unfortunately, some few patients, the stopping mechanism are the anti-inflammatory, that this is happening in the nucleus. So once the virus attached to the nucleus, it started triggering how these inflammatory cytokines start pouring. Then there is an end of it, right? At the end, there is always the markers that need to stop it. So how to stop it? These few patients that are dying, their inflammation is not stopping. That's where in the nucleus and where it is happening. So because with the research is going on everywhere, how we want to find out, identify, while we are trying to understand that basic pathophysiology and stopping that inflammation, we're coming up with some of these modalities. As you know, for the last year, we have been at least coming across that steroids. Out of all of our experience, we know the steroids and steroids and steroids. Steroids are the only, corticosteroids, the only drug until now shown any reduction in the mortality. Whether you use it early, whether you use it late, whether you use it in very severe patients. So now we're focusing on inflammatory, anti-inflammatory drugs, antivirus drugs. All of the antiviral drugs we know we failed because it's not the virus that's causing the problem. So again, that's another different topic. I don't want to touch it. This is a lot of debate going on that issue, when to start the steroids, etc. Having said that, now it comes back to the patients that are admitted in the hospital and the severity and everything going on. I want to give you a few the data that we have, preliminary data that I got, my experience in treating. Then we can discuss about when to start this treatment and what to give and what are the complications that we are seeing in these patients. And just follow up of Dr. Ganshyam's report about their experience about. We have treated about 38 patients in different institutions. Okay, this is not in one controlled institution that I'm doing because I don't have the privilege of Dr. Ganshyam where you can sit in the hospital and get everybody patients and treating it. Unfortunately, I have to communicate with you, everyone, and trying to get some of the patients to treat it and try it. And I'm fortunate enough to few physicians to be either trusting me or trusting the treatment. We did treated the patients, about 38 patients. Out of that, 27 patients survived. About 11 patients could not survive. I was looking into analyzing this patients that are not survived. What's going on? Out of 11 patients, 3 patients had pulmonary embolism. They recovered initially, and then 2 or 3 days after the second dose, when they were improving, then they developed pulmonary embolism and they succumbed to the disease. And then 3 patients developed acute MI. This is the patients, actually 1 or 2 patients, we are ready to discharge from ICU, and they develop acute MI. That's a very unexpected thing that we saw. Again, we talk about it, whether this is the stem cell issue or what else is going on. And 1 patient developed acute cerebrovascular accident. You get almost midline shift, and we couldn't, unfortunately, not even a single neurosurgeon is available to help to decrease the pressure. So that patient also, we lost that patient too. And there is 1 patient developed seizures, and he did not die. I mean, so he's just seizures. He's still on the ventilator. So we're watching him and what is going to happen to him. And 1 patient developed multiple small cerebrovascular accidents, multiple, and we couldn't save him also. And there are 3 patients we started very late stage that they're already infected, they're already septicemic. So that was expected. It was in vain we gave the treatment. So these are out of these 11 patients, this is the category. One of the main thing that we notice is the arterial and venous thrombosis. Whether this is due to the stem cell or is it due to the disease itself, we all know that the COVID itself is a highly thrombotic disease. And in fact, a couple of patients, when we look into that, when we give the stem cells, their D-dimers and all the other markers dropped immediately within 24 hours. I mean, one of the patients that developed acute MI, his D-dimers were 12,000. It dropped within 12 hours to 3,000, and the next day it was 1,000. And then later on, when we were about to think about transferring to from the ICU, he had an acute MI and passed away, couldn't survive. So we believe that it is probably due to the COVID-related thromboembolic phenomenon, which is not under good control. So we tried later on, adding, all our patients are treated with anticoagulation, right? But we tried to add clopidogrel or aspirin with clopidogrel because of the arterial thrombosis. We're not sure how to prevent this. So since then, we have not lost a patient. So I'm not saying that this is the treatment, but I'm saying that it is the small observation we need to evaluate, every one of us who we are treating it. Then it comes to the patients that were recovered how are their profile is. 5 patients recovered immediately after the first dose. They even refused to take the second dose because we were trying to give 2 doses so that we get good optimum. We think that we get anti-inflammatory effect. And 2 doses were given for 16 patients. They all recovered and their lung functions improved within a week after, and they're almost off of the oxygen within a week. To maximum 2-3 patients lasted for two weeks. And then 3 doses were given for 3 patients because they were very sick and they were intubated, they were on ventilator. So they are already on the disease on the ventilator for a week. So they took them for 3 doses. And the 4 doses were given for 2 patients. 1 patient out of that is actually on ECMO. Both the patients that received 4 doses were on ECMO. And both the patients recovered. And 1 patient is completely recovered after finishing the 4th dose. Within a week or 10 days, he was out of ICU. In 3 weeks, he was out of ICU without any oxygen. And I will show you at the end if we have time to, the CT scan that was done before and after the ECMO after the treatment. And there's 5 doses were given 1 patient that was on ECMO. He is still alive. We are still watching him. His lungs were clear. One important finding that I would like to mention here is every one of that, including the patients that could not survive, their oxygenation was markedly improved and their lung chest x-rays and CT scan was significantly better. And 2 patients, I want to tell you about 2 patients that we started treatment after 6 weeks because we were not able to get out of oxygenation. So those 2 patients recovered within 4 to 5 days, out of oxygen. Those who are home oxygen at 12 liters or between 10 to 12 liters. So what it tells us is definitely the stem cells were very effective, especially to control the inflammation. And as Dr. Sairam mentioned, it is not only one in the lung tissue, it is helping in many other tissues. So there is something that these cells are affecting all over the body to control it. So with that, I want to pose a couple of questions, whether how we can prevent that treatment after the treatment to get the thrombosis. Probably I want to ask the other panelists' experience about, is it the same experience they're having with the thrombosis? I do believe that it is mostly because of the COVID. And then the second thing is, one more thing I would like to address is probably Dr. Sairam might be having insight in it, exosomes. Like there are a couple of studies I think I was looking into the exosomes in mixing with the stem cells, or which stem cells to use. These are the questions that we have to ponder, and we have to probably in the next few months we might learn more about these things. I think with this, I'll just ask the panelists to discuss when to start the treatment. In my opinion, with the experience, even the very short and small experience, I think we need to start this treatment when the steroids were not helping. And while you're using the optimum dose of the steroids, still, or corticosteroids, still the oxygen requirement is going up. Before they were ready to get into the intubation, I don't want to wait until they get into the mechanical ventilation. Before that, so if the patient is not responding, okay, with the medication that we are treating or the traditional medication, or if the optimum dose of steroids, why I'm saying optimum dose, I'm insisting here is, we all know the study came in from Oxford, 6 milligrams of dexamethasone, 6 milligrams of dexamethasone, anything, anywhere, which I don't believe that we need to do. Only information that you have to take from that is dexamethasone itself or steroids itself has a role in controlling inflammation. I think we need to treat our patients with just having a pulmonary inflammation and asthma, we are treating with the higher doses. I can't understand why we're stuck with the 6 milligrams. So having said that, if the patient get optimum dose of steroids, and still the oxygen requirement is going up, that's a sign. That's a sign that inflammation is not controlled. I think that is a sign we have to address, that we need to find or look for other therapies that are available. I will leave the panel to discuss on this.
Dr. Kalyan, your thoughts?
Yeah, good evening. Good evening, everyone. First of all, I'm extremely sorry for my position right now. I'm actually on the move in a rural area in Andhra Pradesh. So probably I might get disconnected now and then. Please excuse me. Can you hear me?
Yes, yes, Dr. Kalyan, please go on.
Fine, thank you. First of all, I should thank Dr. Anna Suresh first, because he actually shifted a patient from some other hospital to our hospital, and it was with a strong recommendation when we weren't having a bed. I was actually a little unhappy with that shift, but later on, I am happy that I had some acquaintance with Anna Suresh, and then that was the first patient where the stem cells were given, but that was the patient when the patient was already on ventilatory support, who was having a very low ejection fraction, was also having cardiac failure. So along with other multi-organ involvement, but that patient still survived for a week. And also there was definitely anti-inflammatory effect first time we observed in that. And later on, we have given it to a couple of patients through Dr. Anna Suresh itself. Then we started understanding a different perspective of these stem cells. So we were giving initially for all those ventilated or high FiO2 patients, and then slowly moved towards non-mechanical ventilated patients, those who are on NIV. And as of now, till date, we have given for 18 patients, including my own father-in-law, whom we have lost today. But I'll explain you how it happened, and then it's a different story regarding him. So what finally, after considering all these 18 patients, looking into all these 18 patients, we had a clear-cut 6 patients who have completely recovered. Most of them were on NIV, or I think only one patient was on high-flow nasal oxygen, just about to be shifted to NIV. So all these 6 patients luckily were young patients, around 35 to 40-year-old. So that was one thing which I have clearly observed. The age does matter, at least from our perspective. Point number 1. Point number 2, what I wanted to ask the other panelists as well as Dr. Ganshyam as well, who actually has given me some kind of insights into. I'm very thankful to him, first of all, to Dr. Ganshyam again, also on this aspect of autologous mesenchymal stem cell transplant, which we have done yesterday for our first patient, who is still on an IV support but shifted from some other hospital. So keeping that aside, after having seen these 6 survivors, one thing what we understood was definitely it has an anti-inflammatory effect. We had given from 2 stem cells transfusion to 4 stem cells transfusions in 3 of the patients. So there is definitely anti-inflammatory effect. But the point is, this anti-inflammatory effect is not long-lived. I just want to confirm with the other panelists as well as the speaker. How long were you able to see this? I felt that we were able to see it for hardly 48 to 72 hours only. And then the storm again started reappearing, or the inflammatory process started reappearing. Point number 1. Point number 2, what we observed closely was there was the reduction in the neutrophil percent. But at the same time, we couldn't see a significant rise in the lymphocyte count, especially in those patients who have not survived. Could that be the reason why we were unable to see the survival in those patients, or could that help us in understanding which patient could be benefited and which patient could not be benefited? So I just wanted to highlight these 3 major points. One is the age group. The second one is the rise in lymphocyte count. Is it going to be very important? And the third one is is it going to be long-lived? So these 3 questions I have for the speaker as well as for the rest of the panelists.
Dr. Kalyan, I would echo, the findings from the other panelists as well. Dr. Rahul is also here, who was also there with us in the management of this patient, and we consistently found that in some patients there was a dramatical reduction in the CRP levels, to the point that there were patients who had triple digits, which just came to double digits within 24 to 48 hours and to single digit in the next couple of days. Now, yes, there were some patients where we found that the CRP levels again rose. Now, those were the patients where we gave the second session of stem cells. So again, what should be the criteria where you repeat the second dose, or should you have a time-based approach where you say that I'm going to give my first dose today, maybe after 48 hours or 72 hours or 96 hours would be my second dose, or are you going to base your dosage based upon the inflammatory markers or clinical response? Is something that we need to evolve and understand. Before we answer that, I would like to take the views of Mr. Nedun, who was also the key member who helped us in developing our protocol. Mr. Nedun, you're there.
Hi. So what I wanted to ask you all panelists here. So everyone, we're talking about the stem cells. Everyone stays about stem cells. What type of stem cells that you use, whether you use a hematopoietic or non-hematopoietic or MSCs, what type of MSCs that you are getting, whether it is from cord derived or bone marrow derived, what are the cell dose that you are getting? What are the markers, the phenotype, immunophenotypic marker that you are analyzing before you give it to the patient? What is the cell dose? If it is a mesenchymal cells, what is the cell dose which you are giving? Are you escalating the cell dose once you feel clinically recovering the patient and escalating to some level? So what is the baseline cutoff MSCs that you are giving? And apart from that MSC, what are the other cells which you mean to say stem cells here? Just I wanted to have my idea.
I think Dr. Sairam can. We had a lot of discussions about what kind of stem cells to use and how, and we did evaluate. I think actually Dr. Sairam is very diligent in looking into the stem cells and what kind of stem cells, how we have to use it. And many studies were used about 100 million or less than 100 million, or many other studies used different stem cells. We stick to the stem cells that were derived from the umbilical cord, and also we prefer to use 150 million because we know we're dealing with a disease that is, if we miss the chance, the outcome is very bad. So that was the reason we want to really address and hit it really hard. So that was one of the philosophy that we adopted is taking about 150 million cells. And unfortunately, these cells, once you inject it, they're not going to stay there more than 3 to 4 days. And Dr. Sairam will more elaborate on that. And what happens is the effect of these stem cells, because the macrophages are engulfing and using that exosomes or whatever the mechanism that Dr. Sairam explained. So second step, we're not stopping at the first dose and waiting for the CRP elevated. Why we know that this is an inflammatory reaction that is actually we're struggling to deal with it, and they're almost on the ventilator. Don't forget that the inflammation is all over the body. It's not just in the lungs. We're seeing the lungs because it's an immediate effect, and we're seeing about their respiratory issues and difficulty breathing, but it is affecting the heart. It is affecting the kidneys, wherever there is vasculature, that is affecting, and muscles, it's affecting. So I don't think we can stop with one dose. I think we need to give at least a minimum of 2 doses. And the clinical response, I don't want to wait the inflammatory markers going up. And also, I want to make one more comment about the lymphocytes and the neutrophils. I'm not seeing a major contributing about the, yes, if the lymphocytes start going dramatically up, that's sign of inflammation. That means the inflammatory cells are going up, the lymphocytes are stimulated, they're pouring in. But more importantly, I would like to look into that is even after treating the lymphocytes, after treating the anti-inflammatory drugs, the neutrophils. The neutrophils are the dreaded cells. I mean, if those cells are going up, if you see that more than 15,000, 20,000, actually I put it a mark as a 20,000. If I see more than 20,000 of neutrophils, it's extremely difficult to survive. I can tell you they have significant damage in the lungs, significant damage in the other organs, and as we know now more and more, the tents, the nets, the neutrophil extracellular traps are the major problem in causing the thrombosis, especially the arterial thrombosis. And also we know these neutrophil effects are causing autoantibodies because they trap in the DNAs and the molecules of RNAs, etc. They're developing autoimmunity, and that's going to be a post-COVID problems we are going to see. And we do feel that we have to treat aggressively. And the neutrophil count is one thing I'm really scared. I will always follow. And if that is started going up, I mean, it's very difficult to save the patient.
So, Dr.
And
Suresh,
that's why we want to.
no, Dr. Suresh, what would be the time frame between the two
Go
doses?
ahead, Ganshyam.
Yeah, what would be the time frame between the two doses that you would recommend? Because we kind of empirically thought 24 to 48 hours would be the ideal time frame before we repeat the dose.
We are giving it on 0 first dose, and then on 3rd day the first one. So 2 days gap, and that is what we're giving it. And if we do good response and the oxygen levels come completely down, then we're not pursuing that. And if not, I might give another dose after 3 days. It's giving at least 2 days in between. Yeah.
Dr. Sairam, this is about the allogenic versus autologous stem cell. So who would you prefer giving an allogenic, and who would you prefer giving an autologous, and what is the advantages or disadvantages of one over the other?
It's a great question. Let me answer Nedun's question. So these are, what we are using is umbilical cord stem cells, which are culture expanded, and they have the ICST markers, CD73, 90, and 103. So they're pure stem cells. Coming back to your question, we prefer allogenic by far, clearly, until I saw Dr. Ganshyam's presentation, and I think there is a role for that, and I'll tell you what that is. The reason we pick allogenic is bone marrow has very few MSCs, 0.01 to 0.001% of all the cells that you get from the bone marrow are MSCs. There are, I think, about 1 to 2% hemopoietic stem cells, but hemopoietic stem cells are not immunomodulatory and they're not anti-inflammatory. What we need are MSCs. So when it comes to, and I do use, like I said, the bone marrow concentrate, those MSCs a lot in musculoskeletal arena, and I'm seeing spectacular results, but they're injected into the discs, the bones, and the joints. They're very localized, and we don't need a lot of stem cells. When you're treating a systemic inflammatory condition, you need a lot of MSCs. That's my opinion. And the reason why we like allogenic is like what Dr. Suresh was saying, it's so easy to give 2 doses, 3 doses, 4 doses, some patients 6 doses, off-the-shelf product, simple IV infusion. Getting bone marrow from a sick patient is challenging. And as Dr. Ganshyam said, as the patients age, the number of stem cells come down. It's an invasive procedure. It's difficult to give multiple doses. It can be done, maybe not done, because once you take about 100 cc's from the iliac crest, unless you go to the other iliac crest, it takes a few weeks for the stem cells to recover in the iliac crest. So these are all the issues. And the reason why, when it comes to allogenic, in our mind, it's very clear that allogenic is the way to go. Now, when you look at allogenic, again, you have options, umbilical cord versus adipose. The reason why we picked allogenic is these are day 0 cells, very proliferative, incredibly proliferative, and also compared to adipose. And also the perinatal stem cells do share embryonic stem cell markers, again, showing how potent they are. So, and also you do need liposuction and donors for adipose stem cell expansion, we don't have those issues because we're getting it from what I call as medical waste, easy to get umbilical cords. So it's very clear in our mind why we picked the umbilical cord cells. Now, is there a role for bone marrow stem cells? I was actually, like I said, very impressed with your bone marrow data.
Let me, yeah, please.
Let me finish my thoughts. Very impressed. And so I always tell, I haven't treated as many patients as Dr. Suresh did in India, but I've treated a few patients. To me, because I call myself as a stem cell evangelist, to me, I'm totally sold with the power of stem cells. It's not a medical decision. It's a financial decision. If the patient can afford, you should have stem cells. And the indication to me, like what Dr. Suresh was saying, is I look at COVID as 5 stages: mild, where most of them don't need treatment; moderate, severe, critical, and post-COVID. So when the patient enters the moderate phase and or severe phase, when they're not responding to steroids, that's when we need to intervene, especially if the patient can afford. That's the time to intervene. Critical patients, Dr. Suresh was seeing good results. My experience has been mixed in critical patients. It's probably too late. You want to avoid in that continuum in the patient care. And also I've seen patients who've been discharged. I think Dr. Konir was mentioning this too, is after they've been discharged on oxygen at home, they're still not able to get out of bed. With little activity, the heart rate goes up, the pulse ox falls dramatically. I've treated a few patients and they respond within a week, dramatic change in their outcome. So coming back to the role of what you're doing with bone marrow, I think I'm assuming, I don't know, it's a much cheaper alternative for patients. If it is not, I'm seeing you shaking your head. If it is not, I'm comparing it to umbilical cord cells. If it is not, I'm not sure if that's the way to go, but I can't argue with your results. If that's working for you, go for it. I'm actually very impressed with your results. But it comes with its own challenges. So I would like to end there.
Dr. Sairam, cost was a major issue for us because, when we first looked at the
cost is not an issue here.
With bone marrow, with bone marrow, absolutely no cost. I mean, why we moved to autologous bone marrow was
let me explain to Dr. Sairam. So as far as the MSc concerned, so I have been doing MSc culture in my lab for the past 15-18 years for my all GVHD prophylactic. It's a third party. It's always we recommend third party MSCs with the car tissue, but some hematologists always insist for the allogenic donor marrow expanded MSC for their emotional feeling of patient family related. So it's like, okay, it's fine. That's not a big deal. But we always recommend third party car tissue because it is a class 2 MSC cells. You do not have to worry about anything on that allogenic part because it will not cause you anything. So you can give 100% safely. But the problem is how you make the MSC, whether it is in a 0 passage or passage 1 and 2, how many passage you do. So what is the scalability that you are looking within the frame line and what is your viability? How many cell numbers that you are, the confluence if you see in the lab, in the culture, how many cells you are adopting in one vial? Because I'm also hearing here in Hyderabad, people are saying that I'm receiving one vial, it contains 150 million cells with a cost of something they are saying. It is absolutely wrong. 150 million cells cannot be accommodated in 2 ml vial. I can challenge you openly. So that you have to look into that. how the cells come, what are the suspension media they use, whether when you reach it, whether the numbers are there, whether the cells are active or viable. So this is the major point that you have to take it into consideration before you infuse the patient. Even if you infuse the suspension media to the patient, nothing is going to have, you are not going to have anything in terms of any allergy or anything to the infusion, but the number of cells, you have to make sure this many cells gone inside. So normally we recommend 2 to 3 million per kilo. Initially, if you want to have a whole body inflammation, initially you can go for 2 to 3 million. In 3 to 4 days, if you see clinical improvement, you can escalate the dose to 5 to 10 million. So this is what we recommend for GVHD cases all over this. And also other clinical indication which we use a GVHD. For as far as the COVID concern, what you are looking at to reduce the only inflammation. These MSCs, if it is a viable, good number of cells, absolutely you get 100% the inflammation reduction. So that is 100% sure that you can use it. If it works, it works. Otherwise, it won't harm you. So without any hesitation, you can use it. Allogenic MSCs can be used. And I'll come to now the bone marrow. Why we have chosen bone marrow? For the inflammatory purpose, MSCs we are using, absolutely fine. Apart from that, I wanted also to have a effector cells like NK cells and also other cells like macrophage and other thing, other cytokines. So the early stage before mobilize from the marrow, before it comes to peripheral blood, you have a potential number of whatever the cells which you are looking at the marrow, that we will definitely will have a more efficient work than only MSCs. You are looking at only the anti-inflammatory. I'm looking at the other aspects. NK cells. How many people we just to find out how many NK cells are coming down, and also the T cells, which we are CD4 and CD8. After COVID patient, these are the things. T cells exhaustion. So how many T cells CD4 and CD8 which is coming down? How you are supporting those things to control your viral replication in the system. So these are the things which when we wanted to look into that, I thought it is a better giving bone marrow aspirated cells than MSC, because bone marrow has got a MSC as well as and other effector cells. So I have given a proposal to Icmr long back. I think last year I had given the model MSC combination with third-party MSC plus NK cell. So NK cell can be, we can collect from the haploidentical donor, because the NKT, CD3 and CD56 positive cells can be given safely without any problem, because that CD3 positive CD16 cells will not cause any GVHD, that can be given. So this option is, and also we have come up with the peptides. See, the person who got exposed to GVHD now, the T cells, when you are separate into that, there are two types of T cells in general. It is a naive T cells, CD45RA, and also the memory cells, the CD45RO. So the CD45RO, if you collect it from the exposed donor, if you give it to the patient, so the viral will be controlled in a very much manner, where we got experience in CMV and adeno BK viruses in the hematology department. So we use the same type of protocol. That can be implemented here also in future. If somebody is funding for that, definitely we can take into the consideration where you have a control on the virus. So that is the one part. So this is what I want to tell you. Giving alone MSCs, other effector cells added into the property in the cell population will help and more efficient. The result will be good.
Yeah.
So, yeah, go ahead. Sorry.
No, definitely. There are a couple of issues that I would like to address in the NK cells. The NK cells are itself, they're not antiviral. The NK cells has to be stimulated with become a lymphokine activated killer cells.
No.
And no. So the NK cells are mainly antiviral. They're not anti-inflammatory. See, we are dealing with this. Let's look into that. And we're dealing with this. Already the viral stage is over. Most of these patients, the viral stage is over. There's all inflammatory. Okay, so the innate immunity, how much it is going to be affecting, it's okay, it will affect It will clear up the viruses. It will clear up the viral infected cells. That's a basic principle from the NK cells. I can understand about the RA and RO cells that probably the memory cells may be having problem. If the patient's bone marrow itself can produce and can control it with all these cells that are going, then they should be able to produce it. Yes. So the same NK cells and lymphokine activated killer cells may not be that much functional. That's why I don't think that make much difference. I mean, again, it's a theoretical. I'm not saying that this is what your results are amazing. You know, the results that that Dr. Ganshyam produced was actually amazing. But that is what I'm saying. I'm not sure whether adding these NK cells and the RO and RA cells are going to be any extra benefit. That is one of the issues. Second thing is how much we need. Are you calculating the cells? How many number cells you are getting? I mean, I'm just thinking about, because it is wonderful to use it because it's locally, it is available. You don't have to depend on anybody else. You get that right away from the patients. It is easy. And also, if it is cost effective, then we can even use the post-COVID, as Dr. Saira mentioned. We're going to see this post-COVID syndrome like a pandemic in the next 1 or 2 years. I've been seeing already the last year, I've been dealing with every day with the post-COVID syndrome. And so can we get the autologous immediately and we can treat it? Is it more cost effective for these patients?
Yes. So as far as the NK cell concern, collecting marrow and putting into the IV, it is increasing the circulatory cells, whether it is a T cells or B cells or NK cell or MSCs. MSCs are very, very minimal percentage, but other effector cells, even including TCR alpha beta and gamma delta. Gamma delta has got a viral role, and also the RO cells which we are talking about. Okay, there is a different issue. When you want to stimulate the marrow, for example, if you want to give a colony stimulating factor GCHF, you want to proliferate all the cells, mobilize the stem cells, and increase the circulatory cells. That also one possible. You can give a one shot of Flurix 4 or one shot, 2-3 shot of this one GCHF. That also in a way of mobilizing stem cells from the marrow. But it is not all the cells are precursor cells. Some cells are not precursor that you can't mobilize. For example, MSC. MSC cannot be mobilized from the marrow. So that is the reason that aspiration is one option to have mesenchymal cells as well as other effector cells. For example, 50 ml will not have that many cells. What we recommend 20 ml per kilo, you will be able to collect the maximum the bone marrow and process it and give it up. But the sick patient, people are hesitant to collect that much bone marrow cell. So 150 to 200 ml, if you are able to collect, it is based on the weight, the patient weight. So if you collect it and process it, even if you don't want to give, even you can process it and you just give it as a concentrated cells, that effect will be there, because we are not quantifying the cells what we are collecting at present. We wanted to go for the qualification of the cells. So for example, what are the cells which you are collecting? Start with the total WBC and start with the NK cells, start with the hematopoietic stem cells, and other cells, what are the markers are available in the bone marrow. So probably that we can rule out how many cells which you are giving. It is not all the marrow which you are collecting have all type of cells. It all depends who is collecting marrow, how he is collecting marrow is the matter. So these are the things that is involved. So that we need to standardize. I think probably I work with them and do standardization for the QC. So quality control is a major issue now that we will take care of it. If really you are looking at that interest, the results are good, probably we can work out and standardize the product.
So a couple of things I want to mention, Eden. The cells that we use, they're passage 2. We limit to passage 2. And also, you're absolutely right about the quantity. It's limited to 20 million cells per ml. And these cells are all tested, not every dose, but extensive testing has been done to check the viability of the cells. And not only when we remove from the culture, but also 3 days later in the transport medium. We're looking at plasma light now, or even HPL, to increase the viability by the time they reach the patient. So the number of cells, we have to go by what the lab says. We vetted the lab. We have a lot of extensive discussions. I'm also culture expanding cells here, so know a lot about the expansion process and the quality of cells. All the studies that I've mentioned, the control trials, they have always been passage 4 to 6. We want to go a step further and limit to passage 2 for better efficacy. So I'm not concerned about the quality and the number of stem cells. I'm pretty convinced about that. And I'm a big fan of bone marrow stem cells, because that's what I do for a living. Because FDA restricts us to using bone marrow stem cells in our clinical practice. So my question to you is, I missed that. Is it cost effective or not compared to allogenic off-the-shelf umbilical cord? I think it's about close to 1.8 to 2 lakhs per dose for the umbilical cord cells. What is the cost to the patient for the
Dr.
bone marrow? I'm assuming it's low.
I would answer that, right?
Yeah.
One of the main reasons why we opted for the bone marrow was the cost issue, because
makes sense.
for the mesenchymal stem cells, if you look at 1.5 lakhs per dose average, and anywhere between 2 to 3 doses was needed. So we were looking at least anywhere between 3 to 4.5 lakhs for the mesenchymal stem cells.
Right.
What we did with the bone marrow was the entire cost was coming to not more than 15 to 18,000 per session, which included the charges by the the orthopedic surgeon who was giving his services for aspirating the bone marrow, and the rest was all very, very simple equipment, like the needle, Jamshedi needle, and the blood bag. So it was extremely cost effective. So that's the reason, which was why we kind of tried it. Yeah,
makes perfect sense.
And the second thing that I want to ask was the medical, legal, and ethical issues. I mean, because there were a few reports about the use of umbilical cord cells and the kind of medical, legal, and ethical issues involved. So I just wanted the opinion from all of you. I mean, are there any such liabilities or any such restrictions?
Ethical issue is zero, because they're taken from the umbilical cord, which is a medical discard. Legal issues, plenty. In the US, you cannot use expanded cells at all. That's why I do bone marrow. And legal issues, they still exist even in India, and I think Dr. Suresh can talk about that.
That was
Dr.
another,
Sairam, I was also interested in.
Yeah, that was another actually attractive.
Cellular therapies.
The exosomes.
Yeah. That's what that would probably circumvent that medical legal issues. Is it not?
At least in US, it's not. Exosomes is clearly not allowed in the US. I don't know about India. I'm assuming it's the same. Coming to exosomes, I think it has a very, very, very important role in COVID. There is one published trial about exosomes showing good results. If you look at the mechanism of action, stem cells, like Dr. Suresh was saying, once you infuse them, within a week, they're gone from the body. They're gobbled up by the macrophages. So stem cells per se, they also secrete a lot of exosomes. I mean, if you look at the culture media, when we expand the stem cells, it has a ton of exosomes. Now, does the stem cell, after infused, does it have the capability or the time to create those stem cell exosomes? I don't know. My gut feeling is before they create the exosomes, they perish. Or not perish, but when they're taken over by the macrophages, they change. That's why the effect is long-term, even though cells are gone. So most of my opinion is most of the positive effects that we're seeing with the stem cells is from immunomodulation by affecting other cells, not from stem cells per se. Now, when you add exosomes, you're actually adding exosomes, a ton of exosomes. The dose is like 5 to 10 billion exosomes. These exosomes have mRNA and microRNA, and they go into the cells and do translation, create all these nice proteins that we need. So I think it is synergistic. So our plan eventually is to inject a combination of exosomes and stem cells to get the best therapeutic effect. And so if you look at the published trials and the clinical research, there's extensive research. I mean, not extensive. There's some research showing that MSCs work, period. Especially the culture expanded. We have no question about that. So bone marrow, the first time I'm actually hearing, it's not even published, is through your data. And it does make sense. It has other cells, not just MSCs, which have a positive impact on the patient. I totally believe in that. So yeah.
Just to make a comment also here, just as he mentioned about the microRNAs, and probably that might also playing a significant role in stopping the inflammation, because it's microRNAs do work as an inhibitory RNAs in the synthesis of from the DNA, the protein molecules. So it is not just simply these cells are going and working. I think it's a lot more activity going on by giving the stem cells and probably the exosomes. And another one comment I want to make it is in our few patients that we have seen, the gas exchange, the DLCO was markedly improved. Even patients that were treated after 6 weeks of disease, of suffering with the lung problems or the oxygenation problem. So my feeling is it's probably some local or pneumocyte 2s or type 2s or anything that regenerating, or is these stem cells are stimulating to regenerate or reactivate the local stem cells, the innate stem cells? I'm not sure. I think that Sairam can analyze that. I think that's probably it's more than just a simply releasing anti-inflammatory cytokines or protecting it. It's happening.
Probably.
So basically, what you're doing is you're infusing intelligence. The cells know, they react based on the local environment, and they know what to do. That's the beauty of stem cells. And like Dr. Suresh was saying, it's just not lungs. Any other organ which is affected, it recognizes those signals and it creates the proteins and creates that environment for repair. That's the beauty of stem cells.
So one more net. You have the same indication for stem cells as you have for the chemical immunomodulators like tocilizumab and baricitinib. These are the same subset of patients we say that are the candidates for both of them. I would like each of our panelists to very briefly say, including Chandrasekhar sir, Miruguda, if, how and when you would prefer one over the other.
To be precise, I feel that immunomodulation and immunosuppression, I think, are we still considering tocilizumab in that direction of immunomodulation? I mean, that's the first question which I really wanted to know. I mean, in case if we are thinking in terms of immunomodulation.
Yeah.
Anyone, can you please answer that question?
Yeah, go ahead. Sorry.
Yeah, are we considering tocilizumab in terms of immunomodulation or only?
Kalyan Garu, let me chip in if I may.
Yeah, please.
See, the immunomodulation from tocilizumab is isolated a single cytokine that you're addressing. If you look into the pathophysiology of this inflammation or dysregulation of the inflammation in COVID, it is not just one cytokine. There are multiple cytokines. That is one of the reasons that the study after study after study failed using different single modulators.
Yes.
That is one of the reasons that that the steroids or the corticosteroids were effective, because it's stops almost all immune dysregulation, almost all the cytokines. It affects the whole protein synthesis, etc. So that is the main reason. Now we do these. I'm not saying that there is no role at all for these immunomodulators, but there are, unfortunately, we do not have a criteria where and when and at what time we can use this specific immunomodulators. So at this time, if you look into that recent study that was published, saying that the tocilizumab has a role in a very small window period before the patient get worse and before patient get better. So there is we don't know how to catch that particular 2 or 3 days period. So it's probably the true with almost all the anti-cytokine antibodies, and including the other antibodies that we are using now, the one that cocktails and the monoclonal antibodies. Yes, they do help to control the virus, entry or virus, but unfortunately, these patients' virus is already entered. Once the virus is entered, whether they trip into the severe case where there is uncontrolled or dysregulated inflammatory pathway, or they get by self-limited, that's nobody's guess. So, but at this time, what we feel it is, the role of treating of this disease is basically, even if as an outpatient, start with the corticosteroids and anticoagulation with possibly antiplatelet medications. And if the patient got escalated, then you look into this immunomodulator drugs, whichever that we want to be available, wherever that it can be affordable. And if they're failing, then the only other treatment that we are seeing now, significant improvement in the severe disease, is stem cell therapy. So that's where we are heading, but maybe there might be a lot more treatments might come and in adjuvant, adding this and to help us to control this disease and this pandemic.
So the question is, in terms of secondary infections, which we are facing with some of these previous drugs, the mesenchymal stem cells would definitely be playing a much bigger role. But as Dr. Ganshyam's study was showing, that autologous stem cell transplant is doing a good favor, as other speakers have also told, that other than just the mesenchymal stem cells, many other cells within the bone marrow could be of help as an anti-inflammatory property. So in that case, probably why don't we look at head-on study, or at least in comparative studies, and with autologous versus allogenic, which would be really helpful in countries where in India the cost is very, very important.
I think one of the major points, Kalyan, or in our own, all the patients who did not respond were above 50 years. So I was speaking to Nidun as well, and when I was reading, realized that probably as you age or in the elderly population, this may not be the right approach, because the number of cells that you're going to, harvest from the bone marrow may not be as much as you would get in a younger patient.
Yeah. Yes.
Ganshyam Garu, this to be frank with you, I have about close to 5 patients that are recovered or after 75 age. So that's one of the reasons. Probably now it may be because of the cells that we are using, the P2 cells that are high number of cells. That is it affecting or working for these patients, helping? We don't know. But again, it's all the preliminary data. Even my data is hodgepodge, because I'm just dealing with the phone calls and I'm not seeing the patient. We're not specifically following specific markers. This is just a clinical data that I have gathered in the last 6 weeks.
Because we have been involved directly with the patient, and Dr. Rahul would agree with me. Some of the patients, the response were very, very dramatic to believe. Actually, there was one patient. The first patient that we did came to us from Gulbarga, and a very, very recommended patient, day 12, day 13 of illness, and they were looking at lung transplant as a way of management. Came high flow nasal cannula, 60 liters, 90% FiO2, saturating 90, 91, 92 in awake prone positioning. We offered his initial CRP was 183. We did the bone marrow. Within 24-48 hours, his CRP came down to 24. His breathing kind of stabilized. He was able to sit upright in awake. The FiO2 took some time and the flows took time, but he was able to maintain saturations in supine position. So that's what gave us the kind of inspiration to go ahead further. As you say, Dr. Suresh, I completely agree. I think we are still into the very, very early stages, but I think the confidence that we have got from the different whatever little experience we have probably will encourage us to do this more often and a little earlier than what we have been doing. So maybe as the days evolve, probably we are going to get more answers and hopefully better answers.
I do agree with Dr. Ganshyam. I do agree with Dr. Ganshyam. A similar experience with one of the patients. Yeah, can I go ahead?
No, one second. While you're talking, if I can put a share screen, if possible, I'll show one patient that you can probably realize, how effective they are. But while you can go ahead and continue your talk. I'll probably arrange my share screen if I can. I tried, but I'm not sure. Let me try. Okay, you just go ahead, Dr. Kalyan.
I think we all agree on one point that stem cells definitely seem to have a
response.
Okay, I'm trying to put this video. Hopefully, this will work.
Yeah, but I still have a feeling that in an elderly age group population, definitely it's not. At least I think Dr. Ane has got definitely a different experience. I'm thankful to him. But when it comes to older age group, this has anti-inflammatory property definitely is helping the patients. But the original capacity to come back from the illness also does play a bigger role. And that's the reason why probably we're not seeing the same effect as in the younger population. That'd be one reason which we are looking into, like my father, when we have transfused 4 stem cells, customized back.
Did you able to see the
video?
Video that I played?
Yes.
Okay, so that was the video that was taken before the stem cells, who's a patient on ECMO. You can see the consolidation and even the air bronchogram and everything. This was the patient that was they want to do the lung transplant. He's a 55-year-old. Then I will show you now that the video that was after the stem cells, within a week after the 4th dose of the stem cell. Okay, so I think you're able to see it.
Yes, it looks too good.
Yeah, unbelievable.
Yeah.
The patient was sent home without any oxygen, supposed to get the lung transplantation.
I guess all of our experience are strongly pointing that stem cells do have a role in the management of sick COVID patients. Now, what kind of stem cells, which patients are going to benefit, how are we going to decide what's going to be the dosage? I think probably our own experiences, if we can share and club together, probably we'll all learn and come to a point where we'll be able to identify patients early, and maybe we'll be able to save many more lives.
In India, there will be an ethical issue. So without registering as a clinical trials with Icmr or DCGI, even if you want to look into that as a compassionate therapy, so that can be done. but I don't know how many of you agree with that, but still people are doing it. Even for hematomedical oncology side also, so many people are doing some sort of dendritic cells and other thing as a compassionate therapy. But here, I don't know, even I had attended one call just 2 weeks ago, that Icmr people wanted to say that if you want to do anything, just register as a clinical trial and get it done. Then you can go ahead as a conditional approval for using this type of cells for treating a patient. So this is what the Indian regulatory which we are facing now. So that we need to look into that very carefully and we can take it forward.
How difficult is it, Nidun, to get clinical trial approval through Icmr?
Yeah, clinical trial approval if you want with the data, with the small data. So for in this situation, it is very easy to get.
Do you have any contact?
I think probably.
Yes, I have a contact.
Okay. And is it
I
okay
think
to share
just,
our data
Ganshyam,
with the Icmr, even though telling them that we did it without your approval? Is it okay to share our data?
So you can always say that there is a compassionate with the concern of patient that which we have done. And unless until the patient is going to give a complaint, no one is going to ask you. The compassionate ground that we can do that. But small data, this is a preliminary data which we are experiencing. That data can be submitted and registered as a clinical trials. Someone has to be there, sponsor the whole program, because you can't charge the patient. So in that way, if somebody is sponsoring, so definitely we can look into that. It's not only looking for MSc. MSc is okay. As Dr. Suresh said, he is looking for only for the inflammatory, not for anything related to viral. So if it is acute, if you want to look at the viral as well as the cytokine storm, so both away. So NK plus MSCs, this combination will work out. And if it is a chronic, if you are really looking at that we can work out on the T cell basis. So the T cells peptidator also is available. Interferon gamma secreting cells can be isolated and given to the particular patient where you can get away from the viral load, whatever it is. So there are a lot of protocol which has been designed and it is taking into the clinical trials level in Europe and in other places. So I am closely working with the Miltenyi Biotech Germany for entire my program in India. I represent Miltenyi Biotech here. And we have a lot of protocols for anything which you are looking for. MSCs, people used to say that we need 4 to 6 weeks to isolate cells, but we have a MSC brew media where you can get it in 14 days in 400 million you'll be able to generate. So there are so many techniques come now. So, but people look into that, how it is, it has to work in the laboratory. It is a challenging for everyone. As long as the regulatory issues, because we are facing very stringent regulatory in India, so it is difficult for us to move anything. So once it is, I think, settled down, we should drop it in such a way that we should approach Icmr, get a trial, and go for a commercial purpose. That would work when we are all working together and do something.
So, Dr. Ganshyam,
All due respect, sir, I think we are quite deep into the discussion now, and it's quite a long time that I've been discussing this. And with all due respect, I think we should now call it an end to the discussion. I'm so sorry, Sairam, sir, that you were speaking in something that it was an amazing discussion that we had today, something that we were not aware of, a lot of us, and we had not too much of an insight. But of course, everybody agree that it is one thing that we will be looking forward to have stem cell based therapies for the treatment of not only COVID-19, certain other viral disorders or diseases that we will be encountering in the near and far future. So it was an amazing discussion that we had, all of us. And my dear friend Ganshyam, as always, gave a extensive and a very good overview of the stem cell therapy. And I would personally like to thank Dr. Sairam for his great inputs, to Dr. Suresh, to Dr. Kalyan, despite his personal loss, he was there with us, and to Mr. Nedun, and Dr. Chandrasekhar, who has been there all the time with us. Would take this opportunity to thank everybody of the panel, and I would have wishing everybody a safe day and a bright future. Thank you so much.
Thank
Dr.
you.
Sairam, I would connect with you through Dr. Suresh.
Yeah, that'll be great. Yeah, thank you.
I'm really so sorry, and I apologize again.
That's
No,
okay. No problem.
Can I tell one thing to Dr. Shaira?
We can do one thing. See, we can, Abhiram, you can stop live, let the people discuss.
Yeah, that is a better